doctor. My name is EshikaParuchuri, and I'm studying 11th grade at the Woodbridge Academy Magnet School in New Jersey. I would like to begin by thanking you for joining me in this initiative. My main objective is to educate and empower adolescents around the world to help them construct a healthier lifestyle by working with experienced doctors across different fields around the world. In addition to promoting health education, I hope to inspire many interested teens to pursue careers in healthcare and medicine, not just as future leaders, but as individuals prepared to respond to urgent public health challenges, from everyday medical needs to global crises like the COVID-19 pandemic. Welcome to the Healthy Teens podcast. I hope you are keeping well. This month, I'm joined by Dr.Sujana Priya, who specializes in radiation oncology. She has vast experience in this field, working as a senior consultant radiation oncologist in Hyderabad, India. And for this episode, we'll be focusing on general facts related to this field, public health issues that concern teens, as well as the steps that can be taken to have a healthy lifestyle. And now, Dr. Sujana, can you give us a little background regarding your experience in this field?
Yeah, hi, Eshika. First of all, thank you for having me on your podcast. I'm really glad that I'm here with you today. Yeah, and thank you for a kind introduction as well. Okay, fine, great. Now let's go with a brief introduction of me. So, as you have already introduced me as a radiation oncologist, I'll take it from there. So, I finished my radiation oncology in 2013 from Osmania Medical College. And then I have been practicing. So I worked in a hospital where it was affiliated with UPMC Pittsburgh. So that I was able to kind of connect with a lot of radiation oncologists in the US. And I was very fortunate to visit the US also for a couple of fellowships through my associations with, a lot of doctors abroad. So after that, I went on to finish my fellowship of Royal College of Radiology, UK, and right now I'm working in AIG hospitals in Hyderabad as a consultant, senior consultant radiation oncologist. So that's briefly my background. So, yeah.
Wonderful. Okay, so let's dive right in. How common are cancers in India compared to other countries, based on your experience?
Precisely, I cannot give you the numbers, but the thing is, cancer is becoming more and more common. Again, it depends on place to place in India. So, for example, if you're living in cancers are stratified between men and women. So, women, if you're talking about an urban woman, we usually look at breast cancer as the most common cancer in women. So if you go to the rural population, even now cervical cancer is more common. If you come to men, lung cancer, head neck cancer, these cancers are very, very common in men. So the geographical reasons or the lifestyle reasons or because of many other lifestyle choices, the cancer proportions of the cancer, what is common in India is not common in the West. For example, prostate cancer is very commonly seen in the West, and colorectal cancer is very commonly seen in the West as you age. But in India, it is not. It is becoming more and more common because of the westernization of our habits. But yeah, still, if you look at the broader picture, the cancer cohort is completely different as compared to the West.
Interesting.
Yeah.
And how important is screening and early detection in saving lives?
Yeah, screening is absolutely important and it plays a vital role in picking up early cancers. So for now, if you look at the guidelines, the cancer screening guidelines, most of the cancer screening guidelines are aimed at screening women. So usually cancer screening is more commonly used for breast cancer and cervical cancer. Of course, in India, we don't have a formal guidelines. We usually kind of borrow the guidelines from the West and we try to incorporate in our clinical practice. So that is one thing. And so the medical system or the healthcare system is a bit different. So in the West, you go to the GP and the GP has to refer you unless you have a symptom. you usually don't go and see a doctor. Screening part is different completely. And there is a very structured screening plan or structured screening recommendations in the West for breast and cervical cancer screening. So in US, you have something called US Screening Task Protection Force. And in India, like I said, we don't have a structured program. But yes, a lot of patients do walk into the clinics if they have a suspicion or if they think that it is better to get screened, because people are really becoming aware of all the cancers because of whatever, because of awareness, because of social media, because of the print media, or because of WhatsApp, or whatever you would say. So definitely screening detects cancers early, and early cancer detection definitely leads to better cure rates.
Okay.
So that definitely plays a vital role.
And what challenges do patients face in accessing cancer care?
So again, there are definite challenges. So because most of the healthcare systems are kind of clustered in the tertiary centers, but not anymore. Slowly, the scenarios are changing. Every medical college, the government has taken a lot of initiatives, and also they have declared that cancer is the next big non-communicable disease, and we have to fight cancer at any cost. So the plan is down the lane in the next few years, maybe in the next 10 to 15 years, each district is going to have one or two linear accelerators for sure. And slowly they're diverging and they're slowly going into periphery. The centralization of whatever is there in the cities or tier one cities is slowly they're diverging and going into tier two and tier three cities also. So every center, every city these days is having a cancer center of its own. So that is where India stands now. But even though I say that, but the expertise of how a case is being handled is not is not adequate as on today. But maybe down the lane in the next decade or a decade and a half, probably we might have that kind of expertise also, because of the job market shifts and other things. We might gradually see all those shifts happening. These are all slow shifts which will happen over a period of time. So because of the saturated job market in the tier one cities. So, and coming to the access for the patients here, like in the West, we don't have a private insurance covering us. So either the government insurance will cover us or a personal insurance will cover us, where you cover your family by paying for the insurance. Or the third aspect of it is, like I said, the government schemes or the place of your work and all, they all keep covering your insurances. That is how it happens. Or if you have your own money, you have to do your out of pocket spending, directly go and access care. So those patients will be around 10 to 15% only, where you can directly go and say, I have money, look, I have money, and please treat me. Those kind of patients. But most of the patients in our country, because if the access is limited, so that's the reason they try to get access through the government schemes.
Okay. And moving on, which cancers are more prevalent in teenagers and young adults?
So coming to so we usually we have a small acronym for teenage and young adult cancer. We usually say TYA, teenage and young adult cancers, TYA cancers. So most commonly, we see a lot of lymphomas, leukemias, sarcomas, and brain tumors also are relatively common, germ cell tumors. And these days, of late, we've been slowly seeing a shift in teenage colorectal cancers also. So, which is probably because of some genetic mutations or some genetic, very high penetrant genetic mutation could be there, because of which we are seeing slow rise in teenage cancers. In that context, we have started to maintain a database at AIG hospitals called the GIGR database, GI Young Adolescent Database, where we are pooling all the young adult cancers, especially in the GI. And we are kind of maintaining a database to analyze all the GI cancers, GI young adolescent cancers.
Very interesting. And do you think that this gradual rise in colorectal cancer could be due to the westernization of habits, like you've mentioned before?
Yeah, it could be one possibility, but in the young adolescent age group, I don't think westernization is a problem. It could be because of some rare mutations causing. I could see more of a genetic factors causing that rather than all the environmental or westernization factors or lifestyle choices. So usually these kind of lifestyle cancers or any cancers due to unhealthy habits, because of those cancers usually come later in the life because you need to be exposed for a significant period of your lifetime to get those cancers at a later date. So I don't think young and adult age group they're hardly in their second decade, right? They're not that exposed to all those carcinogens or all those bad environmental factors.
Okay. And how do you usually approach discussing cancer treatment with younger patients and their families?
Yeah, it is a very difficult discussion to have, to be very honest with you, because as you know, as a parent, I understand where they stand, and they'll be having a lot of aspirations, lot of goals, and a lot of plans for the kids, like everybody has. But once they find and figure out that their child is suffering from cancer, first and foremost, they'll be shattered. They'll be in a state of denial, to be very honest with you. So having a very honest and thoughtful and empathetic conversation will definitely, make a change in how we deal with it. The main problem is early cancers. If you're able to, if we find out that the patient is having an early cancer, it is still fine because we are talking about cancer, which we are looking at a cure. But stage 4 cancers, where it has spread beneath the organ and spread to all other organs, the conversation is really going to be very, very difficult. First thing we need to explain. The first thing what every parent they ask is why me or why us. So we have a lot of hopes on the child that the child will take care of us. We have a lot of plans. We want him or her to get married, lead a normal life like their friends and all. But it's just unfortunate. We accept empathizing with them and talking, giving an honest opinion as to what treatments we have and how are we going to deal with. So we cannot go beyond that because that is their own personal struggle. At the end of the day, however, how much ever you do the hand holding in the hospital, at the end of the day, it is a very, very personal struggle, I would say. So, but on a different note, we'll be there throughout their care process. And the only thing what I would emphasize is show some empathy, be kind, and be honest when you're discussing. Don't give false hopes. Don't tell them that some assorted treatment is there, here and there, go and try. Because these are the people where they'll be very, very vulnerable. So if they come, they come and they read about a lot of things on the internet, or they discuss with their friends, and they come, see doctor, we're looking at this therapy, that gene therapy, this gene therapy. There could be a lot of trials going on, but none of them are scientifically proven as yet. So these are the things we have to deal in a very, very subtle way and in a very honest way. I hope I answered your question.
Yeah, definitely. So it's a lot. All of this has to do with like a proper communication, but with like a very empathetic approach.
Right. It's not to deal with in the first instance.
Yeah. And is there any advice that you would like to give to young people to possibly reduce cancer risk?
So, like I said, cancer risk, the prevalence of cancers because of lifestyle choices are very, very less in the young and adolescent age group. But at the same time, if you maintain a good, healthy, and focused lifestyle and very disciplined lifestyle, you might be able to beat a few cancers down the lane in the long run. And also forget about cancers. I'm talking about your general health. So I'll be the best example to tell. I'll tell you the reason why. I was a very unhealthy person, unhealthy adolescent when I was in my teens, when I just joined medical school. We don't have a pre-med like you have in the US. As soon as we finish our 12th grade, we write an exam. Like you give your MCAT and all. So we write our MCATs in India back in the day, and we get into a medical school. A medical school is typically 5.5 years. So once you're not in a supervised position from your parents, you're a teenager and you go out and live with your friends. So you know how chaotic or how much that freedom will give you.
Yeah.
And at the same time, I also utilized the freedom, and I was having a lot of fun. I have put a lot of weight. I was not focused on my career. There was no discipline. So these kind of things have pushed me to a corner, and I have put on a lot of weight when I was doing my medical school. And eventually, when I was just about to enter my post graduation, when I was about to enter my residency, I realized that no, this is not what I want. And I started exercising and I reduced weight. Today, I have come to a point where I run marathons and half marathons.
Wonderful.
And I have a lot of mental clarity. This mental clarity is very, very important. Forget about cancer. Cancer is the next level. This kind of mental clarity as a doctor is very, very important, because when you're taking a decision in the clinic, you need a lot of clarity. You need a lot of clarity to communicate it to the patient or a family. So, how will exercise build you? Exercise will build you a lot of physical and mental strength and endurance. Sometimes you need to work longer hours. So, for that, you need to build a lot of physical and mental endurance and stamina. So, because in India, you don't have a fixed number of 2, 3 patients or 5, 10 patients in a day, tend to see a lot more patients, and the doctor to patient ratio is very completely discrepant. So that is one part of the story of maintaining the lifestyle. So there is a very interesting trial recently published called the Challenge trial, looking at the impact of exercise in stage 3 colon cancer. It has definitely improved survival in patients who underwent surgery for colon cancer. The survival has definitely improved with just a structured exercise program. That is the kind of impact exercise has, be it on your mental health, be it on your physical health, or if it comes to cancers also. But at the same time, not all cancers are related to your physical health. For example, obesity is one significant risk factor for cancer. There is no doubt about it. Be it endometrial cancer, be it breast cancer, these are all the cancers because of obesity. Or even these days, the liver cancer is becoming very, very common. There's some entity called non-alcoholic fatty liver disease. Because of that, the liver cancers are becoming very, very common. These things are completely avoidable. Okay, these are all avoidable, or you call it modifiable risk factors. If you maintain a good, healthy diet, or if you can do some good exercise every day, watch out your weight. So these are the things which will, keep you away from all these kind of, modify. I mean, with these modified risk factors and all, you can keep all these cancers away. Yeah.
Okay. And okay, that was it. We will move now to talk a little bit about how you entered this field. So, can you share us your journey into radiation oncology?
Yeah, like I said, I finished my MBBS from Rangara Medical College, Kakinada. It's a very small place close to Vizag, but the college has a very big history and big legacy of around 75 to 80 years old college that was. So we had a very good college days, and after that, I had to become very serious to go in to pursue my radiation oncology career. So when I started preparing for my entrance, for my residency entrance, so then that's when I started reading. You have to read all the books. You have to, kind of go through whatever has happened, all the latest updates and advances. That is when I started developing interest. There's something called oncology. So because in the medical school, we were not exposed to oncology at all. So that's how that intrigued me, and that was the time where many toppers from the medical profession, they were all going and pursuing radiology. So I got a very good rank in my entrance exam, and all my slots were open. Whatever I want, I can take. Even radiology was open for me. If I had to take radiology, I can directly go and take radiology. So both my parents are physicians, and my mom and dad both of them are gynecologists. So after I got my rank and I was chilling with my friends, I was basically enjoying my time before I, joined my residency. One day my dad called and asked me, Hey, what do you think? What are you going to take? Are you still interested in radiology? Is what he asked me. I said, see, all the toppers are pursuing radiology. Then I said, why not? I was not thinking out loud. I was just, kind of throwing options at him. Then he said, no, no, why don't you pursue gynecology? Me and mama, both of them are gynecologists. We'll probably guide you, this and that. So I said, Dad, I was never interested in gynecology. So please leave me. I'm not going to be a surgeon or a gynecologist. So then he asked me what is going to be your other option. I said maybe I'll just see radiology. If radiology works out, I'll have a better work-life balance and I'll just sit in. And my dad said okay, fine, and he walked away. A couple of days later, I don't know what, my mom and dad spoke with each other, I believe, later on. And one day again, they sat me down. They told me, see, you're a total extrovert and you cannot just sit in a quiet room and just do reporting. I think you need, because they know my personality better than me. They said, I think you will be better off seeing patients and interacting with people. So that way you'll be better off than just being in a quiet room and reporting. So I know because of your personality, that's what. Then that made me think, and I started thinking as to what are my other options. So then oncology came to my mind, and then I've gone through the list, and oncology was there in Usmania Medical College. Then I started calling my friends, and everybody were like, "Are you mad? You got such a good rank, and why do you want to pursue radiation oncology?" So this is in 2010, almost. Imagine 15 years back where oncology was. I said, no, I just want to pursue, and everybody discouraged me. Not one person encouraged me in my friends and peer group. Are you mad? You will be giving a radiology seat to somebody who's not deserving, who's back in the rank. So you have got such a good rank. Why don't you take it? Then I told my decision to my parents. The only thing my dad and my mom said, that's a very good choice. That's what they said. Then I didn't look back. So my prime important people in my life are my parents, and I had to just convince them that yes. My mom and dad did not even flinched a bit. They said, yes, that is a very good choice. Oncology is going to be the future. Go ahead and take it. So then I went for counseling to take, and once I said my option is radiation oncology, the person who is going to put the option and click the seat, and he said, "Are you sure, or are you just mistakenly telling that you choose radiology versus radiation oncology?" I said, "Sir, I'm very sure I want radiation oncology only. I'm not confused." Then he was like, he tried to convince me, Are, why are you doing this? Call your father, call your mother. What is this? You're not doing the right thing. Then I said, no, I'm very sure you don't have to call my parents. My parents are there with me through this journey. They know what I'm doing. So then I immediately took my seat, and I did not look back, and sat in the car and came back. Because if you stand outside, people start talking and giving you, unsolicited advices. So I didn't want that. And there was no looking back, and I never regretted the fact that I have taken oncology. I've never did, and I'm very, very happy in radiation oncology.
Very nice. And what would you say was the most rewarding and challenging part of your training?
So the most rewarding part is seeing patients get cured. So because oncology, in radiation oncology especially, the division is like that. 1/3 of your patients only you can cure. 1/3 of patients they become metastatic. Other 1/3 of patients are essentially palliative. So technically, you're dealing with those 30% of patients those 30% of patients really, give you some confidence that yes, there is something to look out for. And these days, the scope of oncology has expanded beyond horizons, with a lot of systemic therapies coming up, a lot of advancements in radiation oncology, and a lot of integration between systemic therapies and radiation therapies. So we are looking at long-term survivors these days. It never happened back in the day when I was training. For example, if a carcinoma lung patient, stage 4 lung patient came back in the day, we just used to write him off, telling that okay, you hardly can live up to 6 months to 1 year, not beyond that. And that too, I trained in a government hospital where you cannot access a lot of drugs back in the day. So now you have a lot of access to immunotherapies, and thanks to Jim Allison, who discovered, and he was also awarded Nobel Prize for discovering immunotherapies from MD Anderson Cancer Center. So a lot of systemic therapies have come where they're extending even stage 4, you're looking at a survival of about 60 months these days if it's a very good risk cancer. So back in the day, it was not like that. So I think this is the right time where we are in oncology. I mean, at least I am in oncology, where we are looking at good survivals for patients, even though they're stage. We can at least tell the patient, see, hey, even though it's stage 4, you don't really have to worry. We can give you some drugs which will work, and you will probably live at least for 5 years. That's a good time. It's a good time for a stage 4 cancer patient to live. So that is the most rewarding. I would say, I would not say rewarding experience, but I would say this is the most rewarding times we are in right now. Just right time in the right place. That's it.
And from your experience, do you mind sharing a story of maybe a remarkable case that you've dealt with?
Yeah, so I have many stories, but offhand, yeah, I can just recollect one patient where she came with a endometrial carcinoma, endometrial cancer. Endometrial cancer is the cancer of the uterus. So she was in a very bad shape and she was completely bleeding. And the primary treatment for endometrial cancer is surgery. There is no doubt about it. But the problem is she is medically inoperable. She has to be off antiplatelet drug. So a drug which has to be stopped if you have to undergo surgery, if you have to go under the knife. So your blood has to clot, right? When you're So because of other comorbidities, she is a patient of stroke. She's a patient of cerebral stroke. So the neurologist and the cardiologist said, no, we cannot stop her antiplatelets, and she's not a candidate for surgery, and they ruled her out. So that was the time we had a discussion. So we have a detailed multidisciplinary tumor board every day. And we discussed with the multidisciplinary tumor board, and we said, okay, fine, this patient will probably benefit from radiation alone. She cannot undergo surgery. Even though that was not the standard of care, we gave radiation to the patient. And we were very, very skeptical because usually endometrium for intact uterus, we never treat. So we treated, and after 3-4 months, we did a scan, and the disease was completely gone. And we were very, 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 very shocked, and we were very happy, rather not shocked. We were very happy that we could cure her at least for the time being. And this happened, I think, a year and a half ago. And I was not very hopeful and expectant that, at some point, because this is not standard of care, and I don't know when she'll be throwing meds. That was the mindset I had. But recently, she came and she was doing perfectly well, perfectly all right. And she never had any symptoms. I mean, her symptoms have improved and she is having a good quality of life. Sometimes, even though it is not the standard of care based on the patient's condition and other comorbidities, I think we need to take a decision. That is one of the most challenging and most rewarding experience, rather, I would say, which kind of responded even though we did not do the standard of care.
And are these, those moments that keep you going in your career?
Yeah, I mean, yes, of course. These are the positive, these are the rewarding experiences. So, you have a rewarding center in your brain that will increase dopamine, right? So these are the rewarding experiences. Yes, anything which have a rewarding experience will keep you going for sure.
Okay, and just going into a little bit about the different treatments. There are so many different treatments for cancer. So what exactly is the difference between radiation, chemotherapy, and surgery?
So radiation is nothing but we usually kill the cancer cells with using high energy X-rays. We call it mega voltage X-rays. So there are a lot of developments from the time I have trained till today. There's been a lot of developments in radiation, in the field of radiation. So first thing is there are some new machines coming up, and even we are getting a new machine called proton therapy. So it is essentially useful for treating a lot of pediatric malignancies, a lot of re-radiations, and essentially treating patients with a very lesser side effects. So it will take about a couple of more years for our machine to be installed in Hyderabad. So that is one thing. And yeah, I mean, again, it's essentially radiation is like I told you, high energy X-rays where precisely they'll be focused on the tumor and will be killing the tumor with a lot of precision and accuracy.
Mhm.
So that is one part of the story. So now coming to chemotherapy. So chemotherapy are the drugs which we will inject in the body. So we have different forms of chemotherapy. Either you can take it in the form of some chemotherapies can be taken in the form of a tablet. Some chemotherapies can be taken in the form of an injection. So, and there are a lot of newer drugs called targeted therapies
Mm.
where it directly go to the target and act so that it will not act, it will act on your body, but specifically they'll go to the target and act and some form of drugs called immunotherapy these days. So immunotherapy is what we were talking about before. These are the new additions to the medical oncologist armamentarium. So they're doing really wonders. And the immunotherapy acts in a way where it will trigger your own body's immune system and it will make it act on the body's tumor. So that is immunotherapy. So that is the part of medical oncology. And coming to surgeries, there are a lot of advances happening. Back in the day, they were doing a lot of open surgeries. So now most of the surgeries they're trying to do with minimal incisions or a keyhole incisions. Those surgeries are called laparoscopic surgeries. So we have still graduated from laparoscopic surgeries to robotic surgeries these days, where robot. So in some areas of the body, your bare hand cannot go and dissect in those planes because your hand has a restrictive movement,
Mhm.
but the robot doesn't have a restrictive movement, and the robot goes and operates for you. Of course, the surgeon has to be there. Surgeon has to tell the robot that okay, this is where you have to take the plane and this is where you have to do it. And even from robotic surgeries, they're going called they're slowly graduating it to a next level called tele-robotic surgeries, where you will be sitting in New Jersey and you will be operating a patient in India. So yeah, this is already happening in India, but I mean in AIG we haven't started. In our hospitals we haven't started, but a lot of centers as a pilot project they have already started. So you can operate from anywhere because the robotic is you need to have a robotic console. That's it.
Mhm. Very interesting. And do you think that changes like these, the robotic surgery, telesurgery, will make a lot of impact, within the next 10 years or so?
Of course, of course. Even now, the only thing what I would see is a lot of people have to come forward to train.
Mm.
So the only thing what I feel in the younger generation these days, of course, I'm not very young anymore. So the younger generation is coming. They have to utilize some time for proper training because nobody, as soon as you leave your medical school or your residency, you're trained for good, but you still need a lot of patient exposure. 3 years of training or 4 years of training is not sufficient. So I would suggest not to jump into practice as quickly as possible. But train, especially surgeons, train to make your hands free so that you know your hands are going to make wonders because for a surgeon, hands are of utmost importance, right?
Mhm.
Train in a way where your hands are going to be very flexible and you will be able to perform more surgeries with ease and precision. So rather than quickly going and jumping into practice. So at least I think you should work in a very high volume center
Mhm.
where they're performing these kind of surgeries. That is the only advice I can give rather than jumping. Maybe we just have to invest some more time for training.
Okay. And with that, we'll move on to our next section, which will consist of some common myths related to radiation oncology and cancer in general. Okay, first one, radiation therapy makes you radioactive.
No, absolutely not. There are a few radiation therapies where it can make you radioactive, but these days most of the centers they are not doing. So we keep introducing some seeds called iodine seeds or palladium seeds or iridium. Iridium also. So, but these are all temporary. So we try to take adequate precautions. So in India, most of us, I mean, at least I don't do these radioactive insertions in the body. So even if they do, the patient will be isolated completely. We do only for certain cancers and for certain indications. But most of our practices are external beam therapy, wherein this is a very common question patients keep asking. We have kids at home after radiation, can we handle them, or can we play with them, or can we take care of them? Absolutely. Once you're under the linear accelerator machine, if you switch on, only the radiation is going to come and kill your tumor. Once you're out of the linear accelerator room, or rather you call it a linac bunker or a console, you're like anybody else. You're just a normal person, except the fact that you're a patient. You don't have to wear that badge on you and tell them I'm a patient. So it'll not show on you, or you're not a radioactive person. You're like any other person in the world.
Okay. Radiation always causes unbearable side effects.
So radiation causes side effects, but I think I would like to remove that unbearable part. Radiation, yes, for sure, it causes side effects. There is no denying or doubt about it, but only in the part of the treatment where you're undergoing treatment. It is in the acute phase of treatment. So there'll be a bit of fatigue, nausea, vomiting. For example, in head neck cancers, you'll have a bit of a skin reaction like a tan. When you get exposed to a suntan, it will be like a suntan. These are all reversible side effects. No radiation side effects are permanent. Yes, most of them are reversible, but the time taken to reverse those side effects might be a bit longer for a few patients, might be earlier for a few patients. It just depends on how long and how early. That's all.
Okay. Radiation is only used when there are no other treatment options left.
No, it is absolutely not true. Radiation is used in definitive settings where that is the only treatment of choice, or that is the only standard of care. Radiation is used post surgery to so that the patient would not develop, or to prevent relapses. So that second indication. Radiation is also used in palliative care settings where you need to palliate a bleeding patient, or a pain patient. So these are the palliative indications, or if you have a brain metastasis and if the patient is very symptomatic. So these are the conditions where you treat these patients. And at the same time, I would also like to emphasize the fact that radiation also can be given for a few benign conditions like keloid, like hypertrophic heterotopic ossificans, or PVNS, pigmented villonodular synovitis. There are a lot of indications for radiation in benign conditions also. There's been a lot of work which was done by Dr. Bobby Koneru, his radiation oncologist from the US. He's been doing a lot of work in low dose radiation therapy for osteoarthritis also these days. But yeah, it is still in the preliminary phases of work for a countrywide or worldwide adoption. There should be a lot of studies coming up. But yeah, these are the benign indications also where radiation really helps.
Okay. Radiation treatment is the same everywhere, no matter the hospital or technology.
I would disagree with that. So if you talk about radiation, not only the machine, the person behind the machine is also very, very important. So it's the way how you deal with the patient. It is the way how, first thing is decision making, whether this patient needs the radiation or not. So not all hospitals, I'm talking about in India, not all hospitals have a uniformity of radiation machines or uniformity of expertise. So if you go to tier one cities, not all tier one cities have the same expertise or same machine or same expertise. If you go to tier two cities, the expertise might be a little, I wouldn't say completely absent or anything. It might be a little less. The reason being, a tertiary referral center will see more number of patients than a tier two or tier three. If the patient is very, very complex, usually the attitude is, for any doctor, if I'm in the tier two city also, the attitude is, if you don't have that equipment and if you don't have the capability of handling a patient, a complex patient, the usual attitude is to refer the patient to a tertiary care center, to tier one city, where you have all the necessary departments or a necessary equipment or necessary expertise to handle the patient. So precisely for that reason, in tertiary care centers or a tertiary referral center, the volumes what a doctor see will definitely be on the higher side. So for a doctor to be become more and more more and more to have more and more expertise, the main things what they have to look at is the number of patients. If you see more and more number of patients, obviously your capability of decision making and if your capability of treating the patient also will evolve with your expertise.
Okay. And lastly, cancer always comes back after treatment.
Yeah, it is not true because there are few incidents. It is not always true. It is partly true. Yes, cancer does come back. For example, if you have high risk features, cancer it will definitely come back and bound to come back at some point. But if you take your treatment properly and if it detected in an early stage, unlikely that the cancer might come back. Very unlikely. And also at the same time, we have a very strict follow-up protocols when we talk to the patient and we tell them once they finish their treatments. So these treatment protocols, follow protocols are given and followed as per international standards. First couple of years, you follow very closely. Once every 3 months, you ask the patient to come to your clinic to do all the necessary investigations, do all the imaging and everything. From 2 to 5 years, once every 6 months, you have to see the patient in the clinic. And after that, once every year, after 5 years, once every year, you see the patient in the clinic. So the follow up is always lifelong. You cannot say I after 5 years I don't want to come or I cannot come. So that is not the answer which we would like to have. But yes, that's how it is. The follow up for a cancer patient is always lifelong.
Okay. And for the last part of our podcast interview, what are your thoughts on how the field of radiation oncology, or just oncology in general, has evolved within the past few decades? What do you believe has changed most from when you first started your career to now?
So when I started my training, I was trained in a technique called two-dimensional technique of treating the patient. When I started my training, by the end of my training, we have a training period of 3 years. So we gradually transitioned to three-dimensional treatment planning using the CT simulator and everything. We kind of made a bit of an we adopted advanced technology. So after that, I came out into practice, and as soon as I came out into practice, I joined as a fellow. I joined as a fellow in a big hospital, and there I was trained in lots of nuances of radiation therapy and high precision radiation therapy as to because every patient we deal with a lot of care to make sure that the radiation is hitting the target. So there was a lot of changes into because we incorporate something called a cone beam CT when we plan radiation therapy, and we implant something called fiducials when we are treating very small patients, small lesions, and we incorporate them and we track them and treat them. So those are all very latest advanced, high-end advanced technique. There's something called Calypso. There was something called SRS or SBRT techniques. These are all the things which I came out and learned eventually during the course of my work and training. And now we are looking forward for a newer machine to adopt into our practice called the Proton. Like I said, which will come in the next couple of years to AIG Hyderabad. So yes, again we have to go back to school and start learning as to how to treat. Of course, there'll be a bit of a learning curve though, but yes, we are happy to embrace the challenge, and it's always nice to go back to school and start as a student. So they're looking forward for that again. So these are the changes. And coming to medical oncology also, the number of drugs and number of targeted therapies, what we were using back in the day compared to now, have grown leaps and bounds. So the number of systemic therapy options, you can give second line, you can give third line. So the whole idea is to prolong the patient's life at the same time with a good quality of life. Prolonging patient's life with a hampered quality of life doesn't really, make any difference to patient's life, isn't it? So at the same time, and surgery also, I spoke about laparoscopic surgery, robotic surgery as opposed to open surgery. So these are all the technologies which have evolved with me as I transition into my journey in radiation oncology from 2013 till today.
Very nice. And with that, our podcast session has now come to a conclusion. I would like to thank you once again for your time, input, and contribution. This was a very fun and engaging podcast. And for our listeners, don't forget to
yeah, nourish your habits to flourish your lifestyle. So that is the message I would like to give.
Thank you so much.